Calcifications can be seen in a number of other entities in addition to meconium peritonitis. For example, they can be seen in fetuses with a teratoma or other neoplasm that calcifies, in which case they will tend to be pretty localized. They can also be seen in anal atresia, in which cases the calcifications are not peritoneal in distribution, but rather will be intraluminal within the lumen of the colon. So here is an example of a fetus with anal atresia and a rectourinary fistula, in which we can see calcifications that are localized to within the loops of colon. And it's thought that the calcifications in fetuses with anal atresia are most likely to occur in those with a rectourinary fistula and are likely on the basis of mixing of the meconium with urine. Now here is a fetus in which there is a big clump of calcifications, but also numerous calcifications that seemingly were located all throughout the abdomen, and as a result, the possibility of meconium peritonitis was considered. However, later in pregnancy, mild ventriculomegaly developed. You can see the atrium of the lateral ventricle is 11.5 millimeters above the 10 millimeter cutoff. There were calcifications within the fetal head on postnatal CT scan, and postnatal ultrasound showed that the calcifications were actually located within the liver parenchyma, as we see here, as well as within the spleen, rather than being in a peritoneal distribution. And this fetus proved to have CMV infection. So there are, though, a few clues that can help you distinguish calcifications that are peritoneal in distribution from those that are located within the liver and spleen. And one of the clues is to see the calcifications lined up all around the periphery of the liver, just outside the liver capsule, but not within the parenchyma of the liver as we see here. Another common pattern for calcifications that are peritoneal and due to meconium peritonitis is to see a curvy linear configuration of the calcifications along the undersurface of the diaphragm. This is a fetus who has both the periphery of the liver distribution as well as the diaphragm distribution, and this can be best seen in this fetus because of the ascites that helps to outline the outline of the liver. So here are some calcifications at the periphery of the liver. We don't see any calcifications in the liver parenchyma, but we do also see calcifications in a curvy linear pattern along the undersurface of the diaphragm. If the question of meconium peritonitis is raised in a male fetus, always look at the scrotum. Because the processus vaginalis is patent during part of fetal development, meconium can traverse the processus vaginalis from the abdomen into the scrotum, and then the meconium can calcify, just like it does in the abdomen. Here are two fetuses with scrotal calcifications on the basis of meconium peritonitis. In this fetus, we see a large calcification here as well as a number of smaller calcifications. And the fetus on the right has a large calcification here and also has a hydrocele surrounding a portion of the testicle. In addition to calcifications, additional findings can be seen in meconium peritonitis. Among them are dilated loops of bowel due to the underlying bowel obstruction, ascites, polyhydramnios, and the meconium pseudocyst. The meconium pseudocyst is a phenomenon that occurs when, instead of the bowel perforation healing, it stays opening. And as a result, there can be continued spillage of meconium from within the bowel into the abdominal cavity. And sometimes fibrous tissue and bowel loops can be matted around the perforation site, and the meconium just keeps spilling into that area, and a cystic cavity filled with meconium just keeps growing and growing and growing. And these can become quite large and can take up the majority of the fetal abdomen and actually result in expansion of the fetal abdomen. And here we see an example of a very large meconium pseudocyst. Given the way these form, not surprisingly, they often will have septations within them, as well as fluid levels where the meconium is layering out. Now, if one has a fetus with meconium peritonitis and fetal calcifications within the abdomen, if you look at the additional findings, the number of additional findings that you see in addition to the calcifications can actually be somewhat predictive of the ultimate prognosis. In fact, the number of additional findings seen 1, 2, or 3 of the dilated bowel, the ascites, and the meconium pseudocyst are strongly correlated with the likelihood that the fetus will need surgery. In a recent study, when there were no additional findings and only calcifications were seen, 0 out of 18 fetuses needed surgery. Add one finding, and 52% of the fetuses needed surgery. 2 of these findings, 80%. And if all 3 findings were present, all of the fetuses needed postnatal surgery. With that, we'll close by moving on and talking about the large bowel, the colon and the rectosigmoid. The colon has a large range of diameters in utero. Like the stomach, the colon normally increases in size with advancing gestational age, and it can measure quite large, 18 millimeters or more in the term fetus. It is said that the colon is located around the periphery of the fetal abdomen, whereas small bowel loops are located inside the fetal abdomen, more in the central portion. But in fact, the colon has redundancies and turns in the fetus, just like it does in the adult. And so sometimes one of these loops of colon can traverse right through the middle of the fetal abdomen. Here are some examples. The colon will look like a hypoechoic tubular structure within the abdomen in most fetuses. Here we see colon in this fetus, and notice it just goes right through the center of the abdomen. And here's a loop of colon in another normal fetus. Large bowel obstructions are much more difficult to detect at ultrasound than small bowel obstructions, and this is partly because of the wide range of appearance of the normal colon, and also because there's no bowel dilatation in many fetuses with large bowel obstructions like anorectal malformations. In fact, ultrasound is really bad at diagnosing anorectal malformations, very insensitive. There have been multiple studies that have looked at the frequency of identification of anorectal malformations at antenatal ultrasound, and all of them show very poor results. Antenatal detection rates of 0 to 33% in all of the studies. In fact, even in the recent most largest of these studies, of 69 cases of anorectal malformations, only 16% were detected with antenatal ultrasound. That being said, though, in some cases you can detect anorectal malformations at ultrasound, and when you can detect them, the diagnosis is usually based either on identifying intracolonic calcifications in prominent loops of colon, as we see here, or the ultrasound finding of a dilated loop of bowel in the pelvis and lower abdomen, especially one that's U or V-shaped, as we see here in this fetus with an anal rectal malformation as part of a complex cloacal abnormality. And sometimes, although some fetuses with anorectal malformations have no bowel dilatation, sometimes the dilatation of the bowel can be striking. As we see in this fetus with markedly dilated bowel, a large amount of material within the loops of dilated bowel and multiple calcifications within that material. Anorectal malformations are seen in conjunction with multiple different abnormalities, multiple anomaly syndromes. Among 2 of the frequent and well-known associations is the OEIS abnormality. That stands for omphalocele, exstrophy of the bladder, imperforate anus, and spine defects. And another common association that is well known is the VACTERL abnormality, standing for vertebral abnormalities, anal atresia, cardiac abnormalities, TE, fistula with esophageal atresia, renal abnormalities, and limb abnormalities. The fetus shown here has VACTERL abnormality with dilated loop of colon due to an anorectal malformation with calcifications within the colon, as well as non-visualization of the stomach in its expected location in the left upper quadrant due to esophageal atresia with a tracheoesophageal fistula, and the fetus also had additional abnormalities as well. I will finish by pointing out that the rectosigmoid in the fetus can be seen and conforms to the expected configuration of the rectal sigmoid you might see in an adult patient. That is, it comes out of the pelvis and goes kind of in a S-shaped loop towards the left side of the pelvis, as we see here. And this is important to realize that you can see the rectosigmoid in normal fetuses because there is a pitfall that has been described whereby in axial scan planes you can see the rectum and potentially mistake it for a presacral mass if you don't recognize it as rectum. So in this fetus we have an axial scan through the pelvis, and instead of just seeing one fluid-filled collection in the pelvis, that being due to the distended urinary bladder, we see a second collection that was thought on the outside to represent some type of a presacral mass. When this happens, one should scan through both collections. You can confirm that the anterior one is bladder by seeing it empty or fill, or by seeing the umbilical arteries hugging the periphery of the bladder. And then scan through the posterior one in a different scan plane, get a longitudinal image of it, and you can confirm it's rectosigmoid by seeing its typical configuration rising out of the pelvis. So this concludes our discussion today, and I thank you for your attention.